In medicine, an acute red flag is impossible to ignore. Take a patient presenting with sudden, painless vision loss. That symptom points directly to a mechanical catastrophe, like a retina pulling away from the back of the eye. The structural failure is obvious, the diagnostic pathway is clear, and the required intervention is immediate. You find the tear and you fix it. But most red flags are not mechanical. They are insidious. Consider unexpected weight loss. A patient dropping 5% of their body mass over 6 months without trying isn't suffering from a sudden structural collapse. Yet the standard clinical reflex is almost universally singular. The moment a physician confirms unintentional weight loss, the immediate assumption is malignancy, funneling the patient straight into a rapid cancer screening pathway. That reflex comes directly from legacy data. Historically, research on weight loss was conducted in secondary care, examining hospital inpatients or specialized referrals. In those highly filtered populations, the probability of finding cancer inflates to as high as 38%. Applying that hospital-level probability to a general primary care setting creates a textbook base rate fallacy. It assumes a worst-case scenario from a high-risk pool, guaranteeing unnecessary invasive testing for many, while entirely missing the actual underlying pathologies. Out in the primary care environment, the prevalence of serious disease is significantly lower, and the presentation of symptoms is far broader. To measure the true epidemiological probability of what unexpected weight loss actually means in a general population, researchers turn to the UK Clinical Practice Research Data Link. Utilizing this massive database, Oxford researchers built a matched cohort study of immense scale. They identified over 70,000 primary care patients presenting with unexpected weight loss and matched them against nearly 300,000 healthy controls. To ensure accuracy, the inclusion criteria were strictly defined. True unintentional weight loss meant losing 5% or more of body weight within a 6-month period, explicitly excluding anyone on weight loss medications or recovering from bariatric surgery. This sample size allows us to discard the hospital-level bias. Instead of a single assumption about malignancy, we can build a highly precise, demographically stratified model for triage. The primary care data proves that treating weight loss as a singular alarm for cancer is mathematically flawed. Diagnosis must shift from a panicking process of elimination to a calculated probabilistic assessment. The data does confirm one crucial instinct. Unexpected weight loss genuinely elevates a patient's risk for almost every serious disease on record. In epidemiological terms, this relative risk is measured using hazard ratios, comparing the likelihood of a diagnosis in the weight loss group against the healthy control group. When you look strictly at hazard ratios, the extremes are jarring. A patient with unexplained weight loss is nearly 10 times more likely to be diagnosed with malabsorption and nearly 9 times more likely to have an eating disorder. But reacting purely to these massive relative multipliers is a diagnostic trap. Just because a condition is 9 times more likely doesn't make it probable. To map a logical clinical workflow, we must pivot our focus to absolute risk. This is the actual percentage chance for the specific patient. And here is the vital statistical anchor of the Oxford study. The absolute risk of a patient developing any single serious disease following unexpected weight loss remains remarkably low, under 6% after 1 full year. Relative risk proves the threat exists. But absolute risk must dictate the actual sequence of the diagnostic workup. That absolute risk does not distribute evenly. Unexpected weight loss is not a monolithic clinical signal. It fractures heavily along demographic lines. This heat map charts the absolute probability of serious diagnoses, ranked by age and sex. Looking strictly at the female cohort, the assumptions of the cancer-first pathway immediately collapse. For women under 60, depression and thyroid disorders are the statistically dominant primary differentials. They sit firmly at the top of the probability ranking, far ahead of malignancies. Move into the 60 to 79 age bracket, and the persistence of endocrine issues holds. Thyroid dysfunction remains the number 2 threat, even as cancer climbs into the 3rd position. There is also a crucial time variable buried deep within this data. The excess risk for these specific endocrine and psychiatric disorders is highly concentrated in the first 2 to 3 months immediately following the initial presentation. For female patients under 80, the numbers dictate a clear sequence. accessible endocrine testing, and psychiatric screening before triggering expensive, high-anxiety cancer investigations. Switch the demographic variable to male patients, and the diagnostic hierarchy completely inverts. Focusing now on the top half of the matrix, the male cohort reveals entirely different pathology patterns. For men under 60, diabetes firmly outranks all other possibilities, carrying a nearly 3% absolute risk. The critical pivot point arrives in the 60 to 79 demographic. This is the exact moment in the data where cancer finally overtakes all other diagnoses to become the supreme statistical threat. That trend intensifies at the extreme end of the spectrum. For men over 80, cancer risk peaks at 5.28%, closely followed by a high risk of dementia. Age and sex dictate the shape of the diagnostic pyramid. Proving context determines if unexpected weight loss is a metabolic warning or an oncological alarm. With the raw epidemiological data mapped, we can rebuild the clinical response into a targeted triage algorithm. The under 60 pathway must prioritize rapid, non-invasive metrics. The immediate protocol dictates basic blood panels, specifically HbA1c for diabetes and thyroid function tests, paired with standardized depression screening tools. In the 60 to 79 bracket, the pathway splits by sex. Male patients route immediately toward cancer and COPD investigations, especially if there's a history of smoking. Female patients require a dual track, balancing immediate thyroid evaluation with early cancer screening. For the over 80 pathway, the workup expands to include mandatory cognitive screening for dementia and assessments for congestive heart failure, running concurrently with oncological workups. Precise clinical triage acts as an algorithmic filter, protecting systemic hospital resources from unnecessary referrals while preventing diagnostic delays for the patient. This structured approach raises a clinical dilemma. What happens when that initial workup returns completely normal? The evidence demands a strict safety netting strategy. Rather than discharging the patient with a clean bill of health, the protocol requires a scheduled clinical re-review. Because that 6% absolute risk is dispersed widely across a multitude of systemic pathologies, the hazard doesn't disappear if the first test is negative. The risk remains active over a full 12-month longitudinal window. Rigorous primary care relies heavily on epidemiological precision, replacing ingrained hospital-level biases with the specific probabilities found in large-scale patient populations.